Okay, all right. Let's see if I can help with some of the statistics. I'm pretty sure. So what do you make of that picture? Usually I bring some impact slide in the beginning, and there's always something for you to remember other than cramming material. I can just tell you that the background is a Greek island, that I can tell you. So, happy occasion, all right? That's pretty much it. Okay, at least we agree upon that. So, whatever dream, and it turns out to be something of that nature. That doesn't look good, right? I just want you to pay attention to who is wearing the mask. And then something of that nature happens, and I'm going to explain that to you. This is a typical case that came, I think, a couple of years ago, where a patient was on a list of multiple drug resistance TB. And he was told by CDC not to travel. And what he does was that he takes a plane all the way from here, goes to Europe, has a flying time, maybe like 10, 12 hours over there, moves around different parts of Europe, and goes to Greek island, gets married, and he receives a call somewhere over here, one of these honeymoon spots that he was there with his wife that you saw. And the CDC says that you are not allowed to travel because you are having a very dangerous disease, which is multi-drug resistant TB. Just imagine for a moment that the person just got married, right? What he did was that he probably did not listen to CDC advice, and he flies back as well. So he flies back, he's kind of taken in custody at the airport. Okay. Now, they have an interview, of course. This is kind of big time news interview. And a typical case of a multi-drug resistant TB, the point for this kind of impact slide is that there are people out there that you would not guess just by the nature of their appearance, the nature of what they're doing in the life. They're traveling next to you in the plane, so on and so forth. And then all of a sudden CDC becomes panicky. Number one. Number two is that then there are brave spouses or partners. They are still ready to go along with their wedding plan, and they know for sure that their partner is having a multi-drug resistant TB. Okay, the only change, you see the change of the mask. You saw that? So the point in this case was, and it was a very funny story because I cannot recall one of them, probably, maybe this girl, was basically daughter of the CDC person who was in charge of multi-drug TB. So he probably didn't educate her daughter that she got into a so-called a marriage ceremony with a person who was in multi-drug resistant TB. So CDC then had to go out and find out the names of all the people who traveled with this guy and stayed there for 8 hours both way transatlantic. Because if it spreads, multi-drug resistant TB is going to be a big problem. So people are not aware of the problem, and of course they have good reason for that, but I would benefit to the person who happens to be in the family where they are working on multi-drug resistant TB. But things can go out of control. But anyway, so mycobacterium is a very serious thing. Whether we know it or not, we like it or not, but it's out there. Another impact slide, I just want to you to pay attention to a little bit of piercing, if you can see over here. And I just want to give credit to the whosoever professor had this slide. I just kind of copied from his lectures. They're not my slides per se, but I like an idea for comparative studies. So if you want to compare this young girl who has, I would say, I can't really see, maybe 3-4 piercing on her ear over here. And you want to compare with another person who has tons of piercing. Okay? So if you have that visual impact, if this happens to be a gram-positive cell with these kind of piercing, which are some of the ability to cause tissue damage, or some of the enzyme, or some of the structural kind of complexity. So you can compare that with a mycobacterial cell wall, which will be very complex in nature. Okay, that makes sense? And then you can see from here, there are simple, same, I would say, same kind of studs as compared to different type of stud that this gentleman happens to wear. So if you were to compare gram-positive cell wall versus gram-positive versus mycobacterial cell wall, so you can see this is something that you have to put in your mind, very complex and challenging and so on and so forth, okay? Again, I wish I should have put the name of the professor over here who had this idea to compare for students. I may have it somewhere. Now, as you can see from here, and again, cytoplasmic membrane, a lot of proteins. Peptidoglycan is pretty much what we have for gram-positive, right? That you saw in the young girl, we're having a couple of kind of studied like teichoic acid. So if you think these kind of structures over here, which is lipoarabinomannan, as something like piercing, it's going to go pierce through and through, okay? As compared to mycobacteria, where you have two important structures, and both are arabinogalactan and lipoarabinomannan. So these are something very important, and we're going to spend the next half an hour, 40 minutes on that. The other important thing, if you remember when I said that they are acid-fast, because they have mycolic acid. So they have mycolic acid over here. So all these things come in a definitive kind of structure arrangement. And I'm going to come to that. I would want you to know, and I'm going to ask you from either inside out or outside in, what are the structural layers of different parts of mycobacteria in this case. So that's like a journal impression you have. The other important thing, this is just a legend for the previous one. You can read it on your own. The other important thing you can see from here, another impact slide was, if you were to, I picked it up from one of the, what do you call, there is a psychological disorder, especially in young girls, where they think that if you were to lose weight, it's going to beautify them. So there's some kind of psychological illness, especially I think European countries, and they had to stop that. But the point I'm going to tell over here, regardless of how much dieting do, you can lose the muscle mass, but you cannot lose the muscle per se. So muscles would be there, only the mass will shrink. That makes sense? You cannot get rid of it. So if you and she would have the ability, then she would also have an ability of doing a limited chores of life or limited physical effort as compared to another person who have worked the other way around. So she's working to decrease the size, right, muscle mass, and there is another person, same person, who's working on building the mass. Does that make sense? So the muscles are the same, but in this case, the muscle mass is built more than, but both of them have the same number of, what do you call, muscles. Now this is a comparison you have to have. Both may be gram-positive, right? But this happens to be a gram-positive cell wall in terms of the size, as compared to a lipid-rich cell wall. That's what I want to impact on your mind, that the thick, waxy, slippery layer that causes a challenge for phagocytosis, that causes a challenge for drug therapy we have, that's because of the lipid-rich cell wall. And that actually those of you, the other important thing, I'm pretty sure that those people who go in these kind of muscle mass, they surely would take proteins, right? They do take proteins, so they always take proteins. That's why 60% of that mass is coming from transport proteins and porine, and that accounts for 15% of the cell wall in terms of weight. The other important thing for this specific bacteria is that this bacteria has an ability to cause tissue damage. So you can see over here, we talked about piercing, talked about tissue damage that this bacteria may have, right? So mycobacteria basically has a very robust ability of causing tissue damage. The other point I want to make is that only this kind of activity, I'm pretty sure humans can only do. So maybe that will give you an idea that only humans are the natural reservoir of mycobacteria, though we do see disease in animals as well. Okay, now there are some diseases that pose a challenge, and again, I'm going to take you back to type 4 hypersensitivity reaction when we taught you delayed type hypersensitivity. I want you to go back and also compare acute inflammation versus chronic inflammation and cells of chronic inflammation, and also go back and look at one of the structures, which is granuloma. And you can see from here, mycobacteria can be inhaled by both passages, and then they are going to go into the lungs, and then they will basically stay in the lung, and our immune system will try to ward off the damage. In the process of doing so what they will do is that they will put the bacteria in the middle, somewhere over the middle, and then build up a layer of cells around that. That includes cells of chronic inflammation, macrophages, and then again T cells will also come because it has to be a delayed type hypersensitivity. And this kind of structure is, if you see with the naked eye, it would look like a tubercle, right? That's what's called tuberculosis, right? And if you were to look under the microscope, we will see as a granuloma because it's like a granule. So that's the two terms that we normally use. And in the center core, you see caseous necrosis. So if you were to cut open that tuberculous lesion, you will see pussy, cheesy-like stuff, okay? And then many a time, many of these patients will present. The most common form of tuberculosis is respiratory tuberculosis. Not that any other part is exempt from tuberculosis. You name a part, and tuberculosis has an ability to infect that part. Okay? Now, the very first set of lymph nodes that will take this information that a mycobacteria has entered into the system, so we call them as a primary lymph nodes because they are the one which drain the initial, set of tissues in terms of T cell response. So we call that as a primary lymph node, and they also become infected, and they also become cheesy, and they also can harbor mycobacteria. Okay, I'm not going to go in detail. You can read it on your own. A typical response that you normally see with all the presentation of the antigen and T cells coming in, and mycobacteria is going to hide over here. You know, whatever we discussed as a part of a chronic inflammation, as a part of delayed type hypersensitivity, as a part of antigen presentation. So all these things will come into play if you were to look, and the response, again, you can see from here, will be in terms of either a Th1 or Th2. Okay, now, those of you who are coming today, and I did mention that we normally do gram staining, but we have an ability to do acid-fast staining, we call, because mycobacteria would not take gram staining because of the complexity of the cell wall, right? But we classify them as a gram-positive because they have peptidoglycan layer as compared to other layers. But we call them acid-fast bacteria. So all mycobacteria as a larger family are acid-fast bacteria. And again, as I said earlier, that I want you to make sure that you know each and every part. For example, the first part over here, A, is the plasma membrane. Then you have B over here, which is peptidoglycan, arabinogalactan, mannose cap, lipoarabinomannan, and then E, plasma-associated cell wall. So all these structures from A to G, you need to know in terms of the layers, right? So very common question asked is, I'm going to stagger the configuration of the layer. I want you to know which one is there, either from top to bottom or bottom to top, because once we teach you the drugs are going to be very specific, and they're going to act on those particular structural elements of those mycobacteria cell wall. Okay. At the same time, I want you to pay attention to mycolic acid, and you can see mycolic acids over here. F, mycolic acids, they are very important. And does anybody remember there was another bacteria? I said that they have an ability to present a mycolic acid, and they are also acid fast. And I asked this question 2 days ago as well. Yeah. Nocardia. You know, this was the first lecture, nocardia. I said they are nocardia or acid fast as well. Anyway, so these are some of the things that you have to keep in mind. Now, again, cell membrane and different proteins over here. We have peptidoglycan layer, and we have then mycolic acid. So that's a typical mycobacteria cell wall if you were to take off other things. Then again, I want you just to stick in your mind in terms of presenting you with these piercing pictures of some of the molecules which are there that will differentiate gram-positive from mycobacteria cell wall. In gram-positive, we have teichoic acid. As compared to mycobacteria cell wall, we have lipoarabinomannan. So you can see these are some of like strings. They go all the way out, and like sutures, they will keep the structural element of mycobacteria cell wall intact. And that's what we are after in terms of breaking it apart. If you were to look mycobacteria under stain, we call that as Zn stain, Ziehl-Neelsen staining. And there's a special kind of staining, but they stain bright red. So you can see bright red. If it happens to be a sputum of a person who's having active tuberculosis, so very dangerous. Remember, I said theoretically you just need one mycobacteria to cause tuberculosis, because they're going to go into the system and hide there. Okay, and of course you can see the previous one was sputum. So we stained it by acid fast, and the red stain is because of the red carbylfuchsin. And then again, there are counter stains and so on and so forth. I'm not going to ask you, but it's good to know the difference in terms of decolorization. Why is it that the gram-positive get decolorized as compared to another dye that is needed for gram-positive? And there was one of the questions in your pre-labs as well. Okay. As you have figured out in terms of this mycobacteria, it doesn't have that flagella. So it's a non-mortal, and it does not form spore. It's aerobic. And of course, it goes without saying that it's going to love to stay in the lungs because it needs oxygen. As far as size is concerned, you can see anywhere from 0.2 to 0.6 to 10 micrometer in size. So that's like a typical size of most of the bacteria, about like 1 to 5 micrometer. And then again, the other important thing for this bacteria is when we used to grow it, it's very fastidious. It doesn't really grow on every media, right? So it wants to go on a very specific media. And when it grows like, if you see like a fungi, it's a fungal growth. That's why initially when we were looking at those cultures, we thought it was a fungus. That's where the myco word comes from. We call mycobacteria, because we thought it's like a fungus. It grows like a fungus, but it is not, right? It is. It has some factors like cord factor. I'm going to discuss that in a while, that cause that kind of coding in terms of its growth pattern. But again, as I said earlier, the cell wall is very complex. The other important thing for this bacteria is, which is good and bad, that it doesn't have a doubling time like Staph aureus or Streptococci. It takes about like 12 to 24 hours to divide. So it's a slow-growing bacteria. So it may be good or bad, but if you were to take a culture and want to report in 12 to 24 hours, you would not get a report back in 12 to 24 hours. Okay, so that's important. Okay, as far as the whole genus, you can see the whole genus has these three important characteristics. They are all acid-fast, and they have mycolic acid containing 70 to 90 carbons. And they have, the other important thing is that if you were to compare guanine plus cysteine ratio, right, so it's very high as compared to many other bacteria. And as I said earlier, that some of the bacteria like nocardia are also acid-fast, but the difference is that the mycolic acids are shorter. So that's pretty much a question over there. If you are asked what is the difference between a mycolic acid in nocardia versus a mycolic acid in mycobacteria, nocardia have a shorter chain mycolic acid as compared to mycobacteria, which has about 70 to 90 carbons. We talked about that. It is a lipid-rich cell wall, and that's why it is resistant to detergents. Again, it's very difficult to use antibiotics. Actually, antibiotics would not do anything. So if you give broad spectrum antibiotic that you give for gram-positive, negative, nothing is going to work because it's very complex, very complicated, right? And then again, it has a lot of antigens. So a lot of antigens there because all these kind of like spiky things. And I told you that it grows like fungi. So it tends to kind of clump or cord. They're the same thing that we use. We call that clumping, or we call it cording factors that we have in terms of the way they grow. Okay. Now, you can read it on your own. It's pretty much the same thing about the structural elements. We've been talking about delayed type hypersensitivity. I just want to bring you back to the protein that is present on those bacteria which is tuberculin. So instead of giving you tuberculin, whole bacteria, we give you a very small portion, and even it's a purified protein derivative, we call it PPD. So the test that you have is called tuberculin test, or a PPD test, or Montos test. There are three tests with the same name. It's a very purified tuberculin protein. I'm going to give it to you and see whether your system recognizes it or not. So if you've been BCG vaccinated, you would recognize it. If you're not, you would not. And I also told you, other than United States, the rest of the world uses BCG as a protective. They think, which people over here don't believe, that it is protective. And why do we not give over here? Because then if you give BCG, then your tuberculin test will be invalid. There's no point doing it. So you have to do an X-ray. Okay. Okay. So let's go back to mycobacterial tuberculosis. I usually teach it on March 24, but I cannot wait till that time. It's always considered as a commemorative when Robert Koch, the German scientist, discovered in 1882. So the problem still remains 2 billion person. What's the world population? 7. So you can guess. There's a very high incidence. And some of the countries like China, India, have the maximum rate of kind of TB. And in terms of demographics in the United States, the Asians, African Americans, local Indians, Mexicans, they have higher incidence as compared to the white population we have in terms of TB. But you can see it keeps on increasing, and then millions of people die of this. It's still a major threat that we have. And in this country, as I said earlier, they think that foreign-born persons have more chances of developing it. There are many reasons for that, socioeconomic and so on and so forth. But the problem that we are concerned over here is that, especially in the United States, is that multi-drug resistant TB, because it only takes 6 to 8 months, and if you cannot use those drugs, you're done. The other problem I think you are familiar with, there was used to be a time, and I was told when I went for a conference to Hawaii, that one of the island was reserved for people who used to be dumped for having leprosy. That's also a mycobacterial disease. Right now, we do not have such a thing, right? But there are places, especially in India, where there are like hundreds and hundreds of patients who are still suffering from leprosy, very high incidence there, and they kind of, I wouldn't say dumped, but they're walled off in a big area waiting to die. So that's a pretty nasty kind of picture that we have. Okay, pretty much the same thing, a little bit clinical. Again, you can see people are going to cough out bacteria, right? So that's why they were worried about that particular person who traveled 8 hours transatlantic, and all those different short trips it took. He must have shared that airspace. So there is enough for people to pick it up. If it goes into the lungs, that's called primary tuberculosis. It involves lymph nodes, and that's where you would find that. And then again, it can be absorbed from here to your, they can be picked up by alveolar macrophages, which are antigen-presenting cell, presented to your T cells, and then T cell will mount a response. The problem for tuberculosis basically is not bacteria per se, because bacteria doesn't secrete any exotoxin, doesn't secrete any endotoxin. The problem is because of the immune response. In order for our immune system to control it, it messes up the whole thing, and then we have an extra disease. That's why we call reactivation tuberculosis. So you may get that one bacteria 10 years ago, and then your immune system goes down, it's going to come back and cause a problem, especially the delayed type hypersensitivity. That's why these people may, so there's a term, you can be infected, but may not show the disease. So your infection may be in a small part over here. You look at the calcification in the lungs, but maybe it's healed. Maybe your immune system has warded off. So there are a lot of dimension to what happens, especially in mycobacterial infections, and we are still struggling with that. So again, as I said, I've written it over here, and I don't intend to go over here. I will leave it on you. Read out the type 4 hypersensitivity reaction. I also told you when I taught you, one of the things that tuberculosis does is it prevents fusion of phagosome with lysosome. And remember that will give this permission to this bacteria to not to be destroyed by the lysosomal enzyme, also sit in your alveoli as an intracellular parasite. It's not a parasite, but it's going to live as an intracellular organism. Okay, that's why antibodies don't directly play any role. T cells are the ones. It has to be broken up, presented to the T cell before it causes any kind of response. You're familiar with all those cytokines that we discussed. They're all written over here. I don't want to repeat it, but you will see the typical Th1 burden. The problem is that if you look at overall picture of pathogenesis, since it has very complicated antigen, so it tests the immune system in terms of the antigenic load. So it's a lot of antigenic load, and our immune system kind of wards it off and mounts a response. So in the process, we happen to cause tissue damage. Remember one of the slides I told you, the guy, tissue damage is a major issue. So any part of your body, whether it be uterus, for example, whether it be brain, whether it be liver, lung, you name it, right? Even heart, if it has tuberculosis, it's going to cause damage. Tissue damaging effect is something that we are still kind of struggling with and try to control it. The problem that we have, as I said earlier, there are no known toxin or enzyme, but we see tissue destruction. And that's because of the delayed type hypersensitivity reaction, which is an overzealous response by our immune system to contain such a bacteria. Okay, we talked about that. Granuloma, again, a better picture. You can see a couple of bacteria in the middle, and then again, all this is warded off by cells. And these cells are Langerhans cells, epithelioid cells, fibroblasts. The whole idea, as I said earlier, it presents a tuberculous. That's what called tuberculosis. but in technical term, we call it granuloma. So the idea is that we want to contain those mycobacteria and meanwhile process it up to our immune system to make some, to do some help in terms of killing them, but unfortunately it does not. This is a cording factor. As I said earlier, it tends to grow like clumping or cording or fungi. So you can see that's why we thought initially, that's what mycobacteria, myco word comes from, because we initially, before 1882, before Robert Koch discovered it, so we were struggling to find out what's happening. And there are, I told you about one strain, a stain we call Ziehl-Nelson stain, but there are other methods of staining. The most important are auramine and rhodamine. You can basically stain them with, and then see them under the fluorescent light. And I remember myself when I was a master's student in England, working on mycobacteria, I had a big challenge of doing some experiment because it takes months for this mycobacteria to grow. We were testing all different methods to find out the result of our experiments. We cannot wait for 1 month. Okay, so as a young master's student, I remember we developed a method we used to call microcolony counting method. And as you must have figured out by now that I'm very fond of my name, so all your passwords are by my name. So I call that counting method as Fazal's microcolony counting method. And it's considered as a standard method for mycobacteria. Anyway, lymph nodes, you can see you get infected in the lungs, and you have lymph nodes over here. And this may present as inflammation we call lymphadenitis. The other technical clinical nerve is scrofula. So scrofula basically means any lymph node which is swollen and has a opening there, and that's oozing out cheesy material. That's a typical of a tuberculosis cervical lymphadenitis. Very common, as you can see, very common in Asia. It also can present in different type of tissue damage. It's a skin damage, but the most important thing that you will see that if you were to use any antibiotics, it's not going to work. Okay, now this slide, I tried to update it this morning, and I figured out even CDC doesn't give you the update. The only update was 2014. So pretty much hasn't changed anything, so I didn't bother to even worry about that. And you can see from here, disease is very common in Southeast Asia, Sub-Saharan Africa. Why is Sub-Saharan Africa having also TB? Can somebody reason out any particular relation to Sub-Saharan Africa? Even if you're not coming from that land. Can you guess? Weather. But why is it like different weather in different parts of Africa? I thought it's all part. HIV, correct. HIV. Because there's a highest incident, and HIV is going to kill your T cell. If you don't have a T cell for defense, you're not going to get HIV only, you'll get TB as well. That's the reason. Very good. So you can see, it actually says over here. Many a time, the question I asked you are there. Okay? And again, I looked at the newer slide, CDC statistics, and you can look it up. It's from WHO as well. Pretty much the same scenario. The only difference I noticed was that it may look like, like Africa, like Southern Africa, India, probably it's Bangladesh or Burma. It shows you the newer USSR republics, but China happens to be a very big hub of that infection. So very high incidence in Southeast Asia. So if you were to travel in that area, you have to make sure that you have precaution for that. As far as rate is concerned, you can see CDC does maintain. So this is coming from CDC. They not only think of reporting, because, for example, if it's let's say Greenland, they say, oh, there's nobody infected, or any other places like this one, don't think that nobody's infected in this state. The only thing is it's not been reported. There's no statistical analysis. So don't think that, if it's all like clear. So that's another thing in terms of rate of, and then again per 100,000 of population. So the rate may be still high in India, but when you compare with the total population, it goes down because the population is also high as compared to US, where if you have 300 million population and if you have a small bunch of people having HIV, it's going to give a different rate. So keep that in mind in terms of calculation and statistics. I'm pretty sure Kumar must have taught you that. As far as deaths are concerned, unfortunately, as I said, again, this is a WHO statistics. So you can see the industrialized nations pretty much stable. They're trying to, Europeans are doing better job than us, but former Soviet Union is catching up. But there's a problem with this slide. Can somebody tell me what the problem with this slide is in terms of statistics? The problem with this slide is that it gives maximum 2,000, and it's about like 2,000 when people from the former Soviet Union tend to immigrate to European countries. So the incidence of TB in European countries have also risen because of this immigration. So immigration remains a major issue in terms of some of the diseases. Again, number of cases per year till 2007, pretty much high for US, and that's where I said that you can look at statistics, they keep on changing, but by all means, even if you have somewhere from 16,000 to 22,000, and pretty much a standard incidence of disease in this part of the world. Again, this is how bacteria grows, like milky, curdy, cheesy thing that I was talking about. And that's what you see in those wounds as well, that kind of comes out in terms of a very cheesy material, and that's loaded with mycobacteria. Now, how do we diagnose it? As I said earlier, clinical picture, that's number one. People are going to, one of the things, what is hemoptysis? Does anyone know what is hemoptysis? You take, say it again?
Coughing off of blood.
Coughing off of blood. What is hematemesis? Throw. The thing, they're close, but these are like medical terms. Hemoptysis means that you cough blood. Hematemesis basically mean, as she said, throw up. So it's more, one of is coming from lungs, hemoptysis. The other is coming from the stomach, hematemesis. Right? So it's more of the esophagus versus trachea. But this is a typical presentation when you have a person having low-grade fever, coughing in the night, blood, cough blood out. Very common chronic cough and number one sign of hemoptysis. So you can do a tuberculin test, and you can do a microscopy. You can do a direct detection for molecular probes. And then what you need to do is that you have to identify, and I just told you in the impact slide, that gentleman who flew for his wedding had a multi-drug resistant TB. So that's like a dangerous thing in terms of resistance. And if it spreads, then again, we have no control at all. The minimum therapy is 6 months. And you can imagine who's going to take those nasty anti-TB tablets, which is going to cause you nausea, vomiting, so on and so forth. And many times I let pharmacology people teach you, this is called DOT, direct observational therapy. So you put patient in a hospital and you give like 10 pills to them and want them to take in front of you because they're not going to take it. It's so, has so many kind of patient compliance issue. So it's a very serious thing in terms of cost, in terms of patients. Typical tuberculosis of the lung, as you will see in this case. And then again, we are struggling with the treatment. The classical treatment, which hasn't changed for many, many years, is a multi-drug regimen. And the standard therapy is that we give isoniazid, ethambutol, and pyrazinamide for the first 2 months, and add rifampin as well. And then again, for the next 4 to 6 months, we just want to take everything out, but give INH and rifampin. So these are the two. So make sure you know that. You're going to be asked hundreds of times in all the subjects. Classical anti-TB therapy. The only difference is that I'll just ask you the name. I would not ask you the side effects. I'm going to ask you. I will talk about that a little bit in lab in terms of the mechanism of action of those drugs. What can you do for prophylaxis? Well, if you happen to go to those areas where the incidence is very high, I don't know if all the people who are going to go to India are going to take it, because drug itself is not very friendly in terms of compliance. But the CDC does recommend that you want to take rifampin for 4 months and so on and so forth. And we talked about immunoprophylaxis in endemic country BCG. We talked about that. And then again, CDC does maintain active surveillance, and they want to make sure that if you do have, it's a notifiable disease. So if you have a patient, it has to be reported. Okay, let's move to the same family, Mycobacterium leprae causes leprosy. Again, it's typically called a Hansen's disease. The difference is the common question that you're going to be asked is what is different between MTB and M. leprae. They are bigger group. Both of them divide slowly, but this divides very slowly, and symptoms develop over a long period of time. You get infected, develop symptoms 20 years later, and both of them are the problems of your immune system. So your immune system, I shouldn't say that, but Mycobacteria is to be blamed, is going to initiate immune response, but rest of the damage is done by your immune system. And no wonder when these people used to have leprosy, they were considered as antisocial, not to be allowed to live in the community. So put them in the ship, take them all the way to one of the islands in Hawaii, dump them there. That's what they used to do, and wait till they die. Leprosy. Now, when we look at leprosy, we basically see one thing for sure is that there is a very strong immune response. We already know that as a part of delayed type hypersensitivity reaction. And again, all those typical reactions that we normally see, if you are immunocompetent, right? So bacteria is able to induce cytokine production, macrophage activation, phagocytosis, and ideally it should resist and it should clear. But the problem in leprosy is twofold. Let me come back to it after this slide. Strong acid fast, lipid rich, pretty much the same. This is the difference. We are unable to culture on artificial media. We cannot. I know in Texas or Louisiana, probably, these are two states, or maybe part of California as well, where they see leprosy in armadillos. So armadillos, and sometimes if they were to grow these leprosy mycobacteria, they're going to inject in their feet, so it grows over there. So that's something important. We have two types of diseases we call tuberculite and lepromatous. So these are something that you are usually asked. What are the two types of leprosy, tuberculite and lepromatous? And the difference is, as you can see, pauci means less, bacillary. This has less bacteria as compared to lepromatous, which has more bacteria. And there are some other differences I'm going to show you in a while. If you look at clinical presentation, and if you want to assess in terms of cellular immune response versus bacterial count, pauci bacillary has less bacteria and strong cellular immune response as compared to multibacillary, which is high bacterial count and small. So that also will give you an indication that the killing of bacteria, the number of bacteria is directly proportional to your cellular immune response. That's what it means. Again, as I said earlier, there are 300,000 new cases in 2005. It's pretty high. But most cases happen to be in India, Nepal, and Brazil. We do have about 100 new cases in the United States. And another important question that if you're asked that which one of these is more infectious. So lepromatous form is more infectious as compared to tuberculite. You can get it from person to person by direct contact. And you can always have it as a droplet infection as well. Prevalence of leprosy, as we already discussed, very high in these countries. And we also talked about that, Brazil, Nepal, and India. Now, if you were to take a biopsy of the skin where this disease is at, so if you see over here, number A is the tuberculite leprosy. We don't see very many bacteria as compared to the other extreme, which is lepromatous. We see a lot of bacteria. And then there is something we call borderline. So if it's more towards tuberculite, we call borderline tuberculite. If it's more towards lepromatous, we call borderline lepromatous. So these are the 4 different categories that we have. Unfortunately, you cannot easily pick it up in this disease. So if you were to look at these early stages of disease, you can see it's like a early lesion, which is a hypopigmentation. But the only catch in hypopigmentation is it is anesthetic. So it doesn't have pain because the bacteria goes and affects the nerves. Bacteria is going to go to your distal parts because they tend to be cooler, like nose and fingers and eyes. So they're away from you, so they tend to be a little bit cooler. It wants to grow in a cooler environment as compared to MTB, and then again affects the nerve, but you will see this typical case. This is lepromatous leprosy. You see multiple nodules of this person. Each has varying size and is teeming with bacteria. This is a borderline the trophic changes in the hand, and that happens because of the question you're going to be asked that why do patients of leprosy lose their limbs? They're kind of it seems that they're amputated. The reason is nerve damage, vasculitis, and anesthesia. So these are the 3 things which will lead to the trophic changes that these patients have leprosy. Some of the patient will present, we call swelling of earlobes and loss of eyebrows. So these kind of swelling over here, typical. And these lepromatous leprosy, if you treat them, there are better chances of recovery as compared to anybody else. Again, this slide shows you that don't get misled by the appearance, like the lesion that it has. It is leprosy in Africa also, where you do see kind of vesicles teeming with bacteria. Okay. So you can see again affecting extremes. This person is kind of treated as compared to tuberculite. So you can see from here facial palsy because it affects the nerves. So these people come up with visual, figurative, kind of changes or trophic changes that we normally see. And sometimes they may have corneal damages and damage to different parts of the body. And they should be treated. How do you diagnose it? As I said, it's very difficult. You cannot look into the microscope because it's not going to stain. We need to do skin testing to confirm tuberculite leprosy because that's the one we want to treat. Culture is not useful, but I gave you an example. We do culture in those armadillo's foot paws. Again, treatment is like for antimycobacterial. The drug of choices for leprosies are rifampicin and dapsone for 6 months, and then we add clofazimine later on. And then again, you can see minimum of 12 months. So that's the problem with mycobacterial diseases. And then again, you need to do something to diagnose it early and take care of that. Lastly, just 1 or 2 slides, because we did discuss that as a prototype, and we may discuss it again as HIV. Avium is a mycobacteria that causes mycobacterial infection in the birds. Why do we want to discuss that? The reason is because of HIV. Everything's the same. People get asymptomatic colonization, especially AIDS. So the moment if I was to ask you, what do you think is the most common, not most common, but one of the mycobacteria that infects AIDS patients? So this is one of them. It's called, the other name for that is Mycobacterium avium complex, or Mycobacterium avium, or Mycobacterium avium intracellulare. So that same names, depends which book are you reading. And this is a tissue from the AIDS patient. You can see Mycobacterium avium complex, that these people do show mycobacteria. As far as epidemiology is concerned, as I said, they are distributed all over the world. Most commonly in countries where tuberculosis is less common, like United States. So if you don't have MTB, we have MAVM. So that's what it's trying to say. And then again, it could be acquired through contaminated water or food. So that's a problem that we may have, but that plays a minor role. The major role that we have in terms of people who are immunocompromised, especially AIDS, and then they cause long-standing pulmonary symptoms. We again do microscopy for that. Culture is sensitive, we can do that. And in terms of treatment, you can see, again, we have to have classical anti-TB drugs, which are ethambutol and rifabutin. And then again, want to make sure that we can add 2 or more drugs. And for AIDS patients, since I said earlier, you have to have a patent T-cell immunity to fight mycobacteria. You have to monitor CD4 cell count, because that's the important thing. And that's like a key for treating AIDS patients. I don't want to go in detail, but we already discussed what is a PPD test and why do we do that, typical hypersensitivity for reaction. And this is the last one. Where did I copy from? If you were asked the differences between tuberculite and erythromatous, you can look at, these are some of the things that we have in terms of the immune response, in terms of the peripheral nerve damage, and in terms of the incidences that we have for this one. Any question related to